TV News live from anywhere in the world on our website www.coretvnews.com. Click on Live TV on our website and watch us live.
And welcome to Core TV Primetime News.
To follow us on Twitter, click on Twitter icon on our website. On Facebook, click on the Facebook and YouTube to see all our previous news production. You can also watch us live on YouTube. Click Core TV, leave a space, then news. Core TV News, a 24-hour news station.
Welcome back. Thank you for joining us again on Core Digest, exclusive to Core TV News here in Lagos. Of course, the Save Children organization, it's a non-governmental organization that gives more attention to the health of children across the world, came out recently with a figure of the safest places to be a mother in the world. Norway coming first, trust that Nigeria would have also increased the lead to, but we seem to have dropped from the last ranking we had in 2012 way back into 170-something position as it is right now, talking about one of the worst places to be a mother in the world. They also talked about an economic gap, a situation whereby children of the poor are 2 or 3 times more likely to die than that of the rich. I'm joined by medical practitioners on the show this morning. Way on my left, I have Dr. Oluwarotimi Ireti. Akinola is a consultant and obstetrician as well as a gynecologist. Thank you very much for finding time to join us today.
Thank you.
Dr. Dokun Adedeji is also a medical practitioner joining us on the show this morning. Thank you very much for coming.
Thank you.
Let me start with you, sir. Why exactly have you been able to identify why it looks as if healthcare provision in this part of the world is deteriorating?
Well, I will not agree that healthcare provision in this part of the world is deteriorating. And that's the catchword. It's not deteriorating. It's just that it's still, the status is still poor. And I'm sure that a lot of efforts being put into improving that. So using deteriorating will be like going backward. But I honestly believe that with improvement in the standard of living, improvement in a lot of indices, it's not really deteriorating. But then also a lot of the data we had, a lot of figures we had were probably incomplete. And so we're just getting to know the real figures. We'll say, for example, the National Demographic and Health Studies data, which we had in 2008, made maternal mortality in Nigeria rate about 545 per 100,000. And by 2013, the same NDHS came out and said 576. But then we knew all the while, you know, it's statistical thing, we knew all the while that it depended on how many people were captured. It was supposed to be a representative thing, but with more penetration, a larger size and all that, we discovered that it wasn't as good as that. Lagos State, on the contrary, in 2010, that was 2 years after the NDHS came out and said Lagos State had 555 per 100,000. So that probably was more realistic than the 545 that we had before. So I mean, we've had 1,500. About 1990, we were talking about 1,500 per 100,000. So if we're talking about 576, it is an improvement, though it's not where we ought to be.
Would you say you're baffled about the challenges of getting a well-coordinated database in Nigeria? For instance, the Save the Children organization is a UK-based organization. They keep coming out with figures each and every year. From what they have, it looks as if the number of babies that die annually is on the increase in Nigeria. Are you concerned about the fact that the figures are coming from outside Nigeria?
I'm a bit concerned about the fact that figures come from outside, which shows that there's a dearth of information in Nigeria, which should not be so. But as Ireti said, the thing in this country is we really do not care about too many things when it becomes a reality that these are factors we should consider. because there are data if they want to get the data. But the problem is there are limited areas of getting data. I mean, most Nigerians probably will deliver, most women will deliver, probably out of 10 delivering, maybe 4 or 5 will go to a government hospital, and then the rest will go to traditional places or churches or all those kind of places. So you can't get data from there. So unless there's a concerted effort to get data from every nook and cranny, we'll still be worrying about how to get data. And the data these people get also, it is not unlikely to be related to the data they can find. They can't manufacture data. So they probably got the data only from respected places or government institutions. So that's why they can give those kind of data.
Well, I'm happy that I'm talking to a quite older generation. Have you been able to really identify what the challenges are? Because prior to this time, we grew up to hear about free health care provision in Nigeria. And they also talk about how qualitative it used to be. What really are the challenges now?
Well, you know, again, I'll just go back to say that sometimes in year 2000, some people came together. It wasn't a UN resolution. It was more or less like just a consensus opinion that there should be Millennium Development Goals. And when they set them, I think the first one has to do with poverty. Education. The poorer you are, the more likely it is that those things. And then the growth rate, the population, the birth rate in Nigeria is not something to be desired. The truth actually is that we're growing very fast. Don't forget that we were about 53 million or something at independence. We're talking about 170 something, and some people even say perhaps about 200 million. So the birth rate is high. The contraceptive prevalence rate, how many people afford themselves of the opportunity of not having children when they do not having children and all that, is just about 16%. And that is abysmally poor. So the implication of that is that we are having too many people competing for limited resources. That is a major reason. So you find out, for example, that the infrastructures are overstretched, the hospitals are overburdened, and we don't have enough. Again, I don't think, well, that's the paradox, really, because I know, for example, that in Nigeria, most people will tell you that one of the problems we have is that we have a dearth of health workers. They're not many, they're not enough. But I also know, for example, that there are a lot of health workers walking around looking for employment who are not getting it. And you talk about their quality. I also know, for example, that about 40% of the doctors that are trained in medical schools in Nigeria are trained for overseas market. As soon as they get out, they carry their bag and go. So if we have a need for them, then you really can't understand. So it's multifaceted. It's very, very deep. I think people need to sit down really and examine these things to be able to find a way forward.
Most Nigerians seem to understand that quite differently, because many people would tell you that we seem to have more resources. It's just the management that is a challenge. Are you saying that we probably have to also consider the number of children we give birth to at this time and follow after China? What are your thoughts along that line?
There's no way, I am sure, that a lot of things will come into place if we do not really address how many we are. And you know, there's no country really that's populous and just allowed its birth rate and all that to go haywire. That's why you talk about India, one-child policy. That's why you talk about China, one-child policy at the state. Because the truth actually is that the resources are there. We have leadership challenges, again, like you said, in terms of planning, in terms of all that. But the bottom line is that even birth rate that we're talking about is a function of planning. I remember during the military regime, somebody said you have four children per woman.
Oh, yeah.
That's the foolishness of that. Was 4 children per woman. You didn't say 4 children per family. So if you had 5 wives, you could do with 20. So that was the weakness of that. But it showed that at least at that time somebody was trying to think. Because the truth right now is that maybe because of the economic situation and all that, people are having fewer children now. I can imagine that somebody like you would not want to have 6 children.
No.
But I know that about 10 years ago, 15 years ago,
We would have counted our wealth in children.
yeah, they counted their wealth in children, but that was because people also thought that some of them might die. Some of them, you also needed children on the farm hands to assist you and all that. And so there are traditions, cultures in Nigeria where if you had 10 children, you kill a white goat to celebrate it and then start all over again.
Dr. Adedeji, are you comfortable with the provision of government for the healthcare sector? Because many people have also discussed the amount of money, the amount of budgetary allocation that gets to healthcare in Nigeria.
I can tell you offhand and straight away that no medical practitioner or anybody in the health sector that is happy with the provision, budgetary provision made for health. It's like health is treated as an afterthought. And that's why you see, look, my colleague just said, you have hospitals, you build grandiose hospitals, teaching hospitals, but you forget that teaching hospitals are not supposed to treat very basic conditions like malaria and all the rest. So there must be a stratification of medical practice in the sense that primary health is what everybody talks about. That was what Professor Ransom Kuti was saying those years. That look, if we improve our primary care facilities and also improve all those parameters like vaccination, provision of health care to people in the locality, most of these things will not need to come to the teaching hospital. And the thing is, I have not seen personally a kind of good planning according to health policy as to what we need to do as a country. And until those things are taken into consideration, what we're saying is you cannot consider health alone in isolation. What are the interrelated parameters that you need to consider?
That's right.
Provision of good water, housing facilities, and all they all come together to impact on health. And if those things are not, look at our roads. They are danger to people in driving, and imagine the rate of accident we have, and then consider all those things, and then the number of diseases that you preventable diseases that we fall to as a people. If those things are not taken in cognizance, and then budgetary allocation, not just made like that, but most of the money we spend in budget generally is for recurrent expenditure, salaries and all that. What is there for capital? Even in the health sector, there's nothing. I happen to have been a part of the SureP program, and then the government was trying to say they will create about 1,000 primary health by this time. I can tell you that as I speak, it's still limited to about 500. And even many people in those places do not benefit from those facilities. They even started something called CCT, cost transfer, and in which people can come to hospital, and then you pay them money for coming to hospital. Because believe me, people cannot even afford transportation to come to hospital. So if those things are not looked at in totality, we will not go too far.
It's quite amazing also that medical practitioners in Nigeria are becoming more politically alive, because I've had a couple of them talk, probably representing their respective associations, talking about dialogue with federal government as regards getting some benefits here and there. But many are still not quite comfortable with the moral justification of having medical doctors go on strike. What are your thoughts along that line?
That's a very difficult question. That's a question that, basically speaking, any medical practitioner, I do not know one single medical practitioner who will tell you, for example, that who takes pleasure in going on strike. Oftentimes it's something that you weep. When doctors are going on strike, some of them actually weep, they agonize that this is being foisted on them. But then you realize the fact that we are in a system where we all shop in the same market. You want to send your own children to school as well. You've done a lot of grilling to go to school, to do all that. And in the past, in years gone by, there was this thing that there was some respect. People knew, for example, that you are a doctor, some privileges accrued with that and all that. But here we are now, it's the survival of the fittest, sometimes elimination of the unfit. And yet you find out that I can say something for sure, that each time you hear that medical practitioners go on strike, there will have been failure of dialogue, appeal for months on end and all that sort of thing. And usually, I have had personal experience of that. Usually, it is when there is a threat of a strike that those in governance come and say, do you have a problem? And so it deteriorates sometimes to that extent. And then sometimes they get to that extent where the threat of a strike has been made, and then let's look at the problems. And then when you've made a threat, and then it's not addressed, then you become totally toothless. If you then do not, you bark, you don't bite. So sometimes you find out that people are compelled sometimes to go on strike, not because they really want to go on strike, because I know that no doctor really derives any pleasure. It's something that we debate and argue and all that sort of thing and persuade each other, let's avoid this, let's try. So most times when you hear that it is done, it's as a last resort. Or it's just, I think, part of the madness in the system. It looks like the system, when you are in a mad situation, everybody's in a madhouse. So in fact, he who shouts the loudest gets hard. And that is the situation.
I'd love to get your opinion on this, because at one end, some are of the opinion that relatively doctors are still highly paid relatively to broadcast journalists like myself. I recall that while serving with the NYSC, even my colleagues we were not being paid the same. So many people are wondering, if doctors are still highly paid, why would a doctor decide to leave his job if, for instance, it's going to cost another man's life for economic basis?
Would you believe something? That many times that doctors go on strike is not for personal benefit. I need you to know that. It is not because their monies are not paid, or because, though their salaries are poor, you may say relatively, take cognizance of the fact that the years of training and the expectation from those people, they should be paid commensurate manner. But what many times, I am aware of this, because I speak to my colleagues. I left public practice for a while, but I see the state of the hospital. If you want to go with me to Ikeja, maybe Lasut now, go to a consulting room. No person, a doctor worth his salt, if not because of the calling of his profession, will sit in those consulting rooms. There's nothing. A friend of mine got admitted to Luth a while ago. There was no bed sheet. There was no running water. The people bringing the food to feed these people carry the food on their head. Luth. So when a doctor practices that kind of, he feels degraded. That this is not medical practice. It is more like apothecary. And then every test that is done, 90% cannot be done within the hospital premises. They're done outside. And then in Luth, I can say this, my friend, when the blood is taken, there were no sample bottles, specimen bottles to give them. They will carry those things in syringes to the outsiders. By the time they get there, it's clotted. Go back and do the same. This is teaching hospital. Is that a place where a doctor, I wouldn't want to practice in that. That was why I left. You see, I don't want people to think, and I'm glad you asked it, that when doctors go on strike, we go on strike for personal benefit. Sometimes it's only the last point, in the sense that they promise you they'll pay you call duties, and they tell you what they will be paid. You will not be paid in 9 months. So how do you continue to do this? And then sometimes the government changes. Who pays what is owed? And if these people don't make noise, as my colleague said, who's going to listen?
But is it possible that these incessant strike actions that we've experienced in the health sector in Nigeria has contributed to the increase in childbirth mortality has been reported by this organization?
No, I don't think so. No, I don't think so. Not directly. Look, if you go to people and interview them, those who go to hospitals at all to deliver their children, out of 10, maybe you find 4. So it's not as if, because it is the fact that in the very elementary stages where there should be primary health, that people should access this, because it's not only coming to hospital to deliver that is important, it's the antenatal section of it. A pregnant woman, does she have access to antenatal delivery, antenatal services? If she doesn't, If she comes to Lu to come and deliver, the child dies, and then they say, oh, the hospital is bad. But she never had an antenatal. But it's when they have primary health close to them that they can attend at affordable price and then can get treatment. These things will go now. It is not as if because doctors go on strike. It is because our health sector is in crisis. And we just need to look at it in a complete picture to understand what the process is. You see, the thing that happens in Nigeria, we like scapegoatism a lot. Oh, something is wrong, it must be doctors. Oh, something going, it must be this person. No, that's not the way it works. In other countries, people sit down to look at the genesis, and then you can tackle it. But if you say doctors, what do you want to do about doctors? You're not, I mean...
Sorry, I'm not actually convinced. I'm honestly not actually convinced of the veracity of those data that we bandy about. Okay. A lot of them are estimates because I do not know where they get their information from and all that. So sometimes it's not something that you can actually cut your neck and say that is the thing, put your hand on your heart. But yes, indeed, when you talk about, you said incessant strike, because the truth actually is that the hospitals have different professionals. But again, when you stand facts on the, truth on this, and then you find out, for example, that there are so many cadres in the health sector. There had been a lot of peace in the health sector, but then even by government action or inaction, sometimes you actually bring about crisis. So that if you do not know, for example, who is the head of a team, everybody knows that medical practice is teamwork. Or if you have teamwork and you make the mistake of, if you have two captains in any ship, they say it would sink. Then you find out, for example, that there's a lot of competition in the health sector. Most of the time when they say hospital sector is on strike and all that, it's not the doctors that are on strike. And sometimes the people who are supposed to open the gates go on strike, and anybody, what the public says is that doctors are on strike.
Let's take a commercial break here. When we come back, we'll also consider the role the private sector is playing in all of this as regards the safety of mothers in this part of the world. Stick around, don't go away.
It is often said that the future belongs to those who believe in the beauty of their dreams. But what about the things in life that actually inspire us to believe? Like the things that drive us, the things that move us, and even the things that remind us that the sky really isn't our limit. Because when we are inspired, we are led to future greatness. But first, we just have to believe.
One day I want to build Nigeria's first aeroplane.
I know. One day you'll make us proud.
Rich and creamy pig, extra fortified with 28 vitamins and minerals. Here's to 60 years of nourishing dreams and inspiring the future. The future is bright. Reach for your peak.
Introducing Smart Connect, we get plenty awoof to allow you talk, text, and browse nyafu for tin in the money.
Igwe. Say you know say with just 200 naira recharge card, Airtel they summer me with 200% bonus to yarn more with any network.
Now you not call me your fiance.
Relax. In fact, I don't buy your own Airtel SIM every day. As correct vessel, anytime I recharge 200 naira and above, Smart Connect they summer me with free internet to browse. If you want to make your family follow you enjoy, buy your 4-in-1 family pack for the price of one. Oh baby.
Akururu. This girl too, na family and friends.
No carry last to buy your Airtel SIM today.
Airtel, the smartphone network.
Mothers in Sub-Saharan Africa endangered species. Of course, it's the report of the Save the Children International ranking Nigeria low in the safest places to be mothers in the world. We're joined now by Kayode Isa. He's the Commissioner for Health in Kwara State. Hello, Commissioner. Can you please shed more light? I have two medical practitioners with me in the studio. We've been discussing this for quite some minutes now. There are thoughts as regards the relationship that exists between the government and medical practitioners and how these relationships affect or impact on the quality of healthcare available to the average Nigerian. Can you shed more light as regards this development?
Yeah, thank you very much. For health administrators in Nigeria, it's a matter of concern that the relationship has been cordial for some time. Sometimes it will not be cordial. It is not good for our people because you don't have to only look at the government input into the health sector and then the output that is expected. You have to look at the impact of government policy on health on the people of Nigeria. And this impact we will not be able to have a good measurement of it if there is no cordial relationship between the government, who is the largest employer of medical workers, and these medical workers. So that is the situation now that we are facing.
There are fears as regards how much money respective governments invest in the healthcare. You consider the national budget and you probably will be blown away at the percentage that is being accrued to the health sector. Does that bother you at all?
Yeah, it bothers us so much. It's not even the apportioning of budget figures to the health sector, but even the little that is being apportioned for government to have the sources of the fund to be expended, that is actual budget spending. When you look at even the little amount that is being budgeted, and you look at what is being expended at the end of the day, you will see that we still have quite a long way to go in Nigeria. And also yesterday when I was contributing to your program, I said that we need to embrace health insurance in Nigeria. We have started it in Kwara State and it has worked for us. We have started the community health insurance scheme since 2007 and it is working for us. We've had more than 20,000 skilled bats since we started the program, and out of this 20,000 we have about 10% of which is cesarean. When you look at it, you will see that by indices, maternal and child morbidity will start reducing once our people have access to quality health care.
There are also challenges of having an exhaustive database. How do you measure your success without actually knowing the number of people who are being affected on a daily basis?
Yes, you see, there's this mortality, assessment. You will be able to access those that are actually coming to get the skill, attention. But for you to be able to measure the deaths out there is not an easy task. You agree with me that in Nigeria, one of our major challenges is statistics, getting accurate statistics for us to be able to, know the exact level of challenges that we're facing.
It's all right. But let's also probably ask you how affordable maternal health care is for people in Kwara, for instance.
Well, in Kwara State, through our community health insurance scheme, we've been able to put down a program that has been backed by the edict. That means even if there is a government change, the program will continue. The program was put down initially at 300 naira per annum. Now it has been moved to about 500 naira. Even with this 500 naira, we are talking about $3 per annum, and then you have access to qualitative healthcare delivery throughout the year. Because of this affordability, healthcare has become accessible in Kwara State. It is also very much available because we not only put down the insurance scheme, we are also fortifying our system with human resources for health. And then through the primary healthcare unit of the health system, the secondary healthcare unit, and the tertiary healthcare unit, as we are renovating, upgrading our infrastructures, we are also equipping. And then we are putting huge sums of money to back up this insurance scheme so that we've been able to have continuity. Since we started in about 2007, we've had up to 80,000 enrollees, you know, and then we have also been able to sign an MOU with our partners to scale up to 600,000 by the year 2018. That is majorly for the rural communities in Kwara State and also suburban communities in Kwara State. And the program is working. We've had instances where health practitioners have come to study our system from Tanzania. We've had it, you know, also across Nigeria. It's becoming a model which is being studied by health practitioners around the globe.
Before I let you go, how exactly does this insurance work? What's the financial, what do you call it now? What financial donation really does the mother in this particular case pays in exchange for all of these facilities?
Yeah, what we have done is to encourage skill back by providing not only the infrastructure, the human resources for health, but also to provide some incentives to even lure our pregnant women to come to the hospital to come and deliver. We recently produced about 30,000 delivery kits, which we term here as mama kits. And this is one of the major problems of pregnant women. By the time they want to deliver, and then they were asked to go and bring these delivery kits, the cost of buying them becomes Herculean. When we saw this, we decided to, you know, have a go at that. And then with that, we were able to have quite a number of them.
And you give these kits out for free?
We also have something.
Honorable Commissioner, do you give these kits out for free?
Free is free.
It's all right.
It is free. The cost of enrollment on our community health scheme is just 500 naira, which is just about $3, which I've mentioned. We also have the personal health record. The personal health record takes care of a pregnant woman, the child from pregnancy up to delivery, and then the child from age 1, that is 1 day old, up to 5 years old. The personal health record takes care of all the records of that child from the womb up to 5 years. We also give it out, you know, for free.
It's all right. It's all right. Thank you very much for finding time to join us this hour. We shall also take on you subsequently on our show. Having spoken with Kayode Isa, is the Honorable Commissioner for Health in Kwara State. That seems to be the situation, doctors. On the hand of medical practitioners, we hear much of the needs and the challenges. But then when you speak with a government representative, they also have a load of achievements and many landmark innovations that they've brought to the table. How come both needs and provisions are not meeting to improve our healthcare speedily and to make it stand abreast with what is obtainable in developed climes?
Well, I guess part of the problem would be that a lot of the things we do must move beyond symbolism. You know, in politics, symbolism is a very important thing. Where we talk about health insurance, and it is fantastic because it's done all over the world. But I believe that by the time end users all stakeholders can sit down genuinely and formulate how those policies will work best, that's the time we begin to reap the rewards from them. Because when you talk about the poultry sum, the chain, the value chain and all that, it's so much that sometimes the amount of money that you're talking about that you're committing to them becomes so irrelevant. There's this saying, I guess, that health is wealth. People still do not understand the fact, for example, that good health is a basic provision that if you are not well, you basically cannot work, and that you cannot create wealth. So there's no progress for anybody. You wait until you're really down there and you're sick. That's when you appreciate the value of health. The needs are there and they're mounting. I don't know whether it's, I mean, I belong to an association, I told you that, I mean, that's Society of Gynecology and Obstetrics of Nigeria. And we looked at these figures that you're talking about. We enlisted our international partners, that's our parent body, and we talked about something called maternal death review as a very simple tool that's being used in developing countries, in developed countries, to try and mitigate this terrible calamity that we call maternal death. And the National Council of Health has adopted this over 3 years ago, but it's been unable to roll it out. It's by force that we've been able to get some governments to commit physically on the field. I know Lagos State was, and that started in Lagos State about 2012, 2013 immediately. I also know that there are about 3 other states, or 3 or 4 other states in the whole country that are keyed in on this. But then this is something that other people moved, brought in funds, brought in everything. We rolled out another program about 3-4 years ago because of the bad indices, poor indices that you're talking about. We call it Volunteer Obstetrician Scheme, which means that an obstetrician at no cost whatsoever to the system adopts a primary health care center that's nearest to him. Okay. He mentors the people who work there. He renders help, assistance when called upon, so that maybe once a month, once a week or something, he pops in. That's absolutely free of charge and all that. I can tell you, for example, that it's not up and running simply because I do not think that National Primary Health Care Development Agency was involved with this, but then it was going to die on that table. And so you find out, for example, in Lagos State, we've had to push and push it and all that sort of thing, so that we can help in those, because like you said, there's this thing called Alma Ata Declaration. It's way back, something like about 76 or something, that says that America in the 60s, in the 70s, had very poor maternal indices, very poor maternal indices, until they talked about this stratification and being able to keep seriously to deliver more people there. And so these things are recognized. I am sure, for example, even with the Sure P talked about and all that, that the Federal Ministry of Health designed a project which they call MSS, so that even midwife service scheme, even midwives that have been retired and all that sort of thing were recruited. There were part payment. The federal government pays some amount, the local government or state government pays some amount, a counterpart funding kind of thing. And the truth actually is that there was no way it was not going to, because in Nigeria as today, only 39% of women deliver, have skilled birth attendants. And those skilled birth attendants also includes the auxiliary nurses and all that. So that somebody who knows what to do when anything goes wrong, because things go wrong, from resuscitating the child, like you're talking about, to the mother bleeding to death. So the truth actually is that if you don't have a skill, and that's been recognized worldwide as a key. Okay. And yet, all efforts, everything that's available to make that happen, we've not keyed into them. So even so, I think it's a mindset. People don't appreciate the fact that these things are important.
Another issue raised in that report is the economic gap. You know, where you have a situation that tell you that children of the poor are 2 or 3 more times likely going to die at childbirth relative to the rich. There's also this there's this thin line between the public sector and the private sector. It looks as if average Nigerians who are well-to-do would prefer to patronize private hospitals relative to the public ones. Well, what impact do you see all of these having on healthcare in Nigeria?
You see, let me tell you something. I think Ireti said it very well about symbolism. You know, my challenge or my worry in this country is we want to clutch onto something to have without a thinking process. It doesn't work. Look, imagine the population of people who have bad attendant coverage. 39% of our women. That is criminal. And what you will find, all those things insurance we want to do because it's the nice thing to do. But do we have any thought process behind this? If you ask that, the commissioner said $3, what can $3 offer in terms of health chain? Per annum, $3 per annum. What would that do? The thing is, if we then look at, let's take Lagos State. If you don't use Lagos town or Ikeja as representative of Lagos State, go to a waterside in Lagos. They haven't heard about health insurance before. They don't even have any primary health facility to attend. And you see, the thing is, everybody is talking about the end stage. What about the process? A woman gets pregnant. Does she have any counselor? Has she attained any antenatal procedure? And then the only thing you want to consider is mortality rate. Of course, it will be heavy in those areas where there's no coverage of the basic things to do. In some of the centers that I have visited, they talk about family planning service. If you take 10 people, only 2 women, probably, maybe in Lagos you have about 6 knowing about family planning, and that's Lagos town. Go to the suburbs, in Ikorodu, how many women? So those are the things. And as Ireti said, if we do not sit down to have the stakeholders agree on the modality of a policy, it can't work. You can't just throw a policy and expect everybody to catch on it. It's the same you talk about public sector, private sector. Each sector has its role, but what is the role? The private sector in Nigeria, everybody now runs to private hospitals, but check the standard of the private hospitals. It's the same like public schools. People are running away from public to go to private school. You say private school under a test or what do you call it, and also you call it private school. It's not even what it offers. It's not as good as what the public sector will offer. The same thing in the health sector. You see a woman who just closed, she's a nurse or a retired auxiliary nurse, and then she starts a clinic, let's say it's a private sector. What are the guarantees? Do you understand what I'm saying? So those are the things that we must look at. And it's a spectrum. We can't just jump on the bandwagon of everybody because they do it. We want to do it without a process. What we lack in this country is a sitting down, is a thinking through of a policy. It is not just to jump on a policy and say, this is what we want to do. You first of all know, okay, in the place where they've done it, America in the 60s had terrible maternal figures, but today, America is not even one of the best places. It doesn't have even the best health facility or delivery to the people. Scandinavian countries have better records. So it tells you that the Norway that you quoted, what they did was not just the figure, was to look at those parameters that affect a woman. That's what Obama is saying. There must be pay parity between a man and a woman because you do the same job. Why should a woman earn less? And without economic power, you cannot access all these things we're talking about. So the thing is, as we think about health, we must think about a woman in totality. Does she have education? A woman works on the farm, she's a farmhand, or she carries all these trades when they're building. How can she have the same opportunity of care? So those are the things we need to look at. It's a major thing that we need to sit down, assess it, and then move on with it.
There are also growing concerns, before I let you go, about the attitude of medical practitioners, especially in the public sector. Many have complained about negligence. I had a friend who talked about, who shared a very sad experience how his dad died at the University of Ibadan Teaching Hospital. yes, UCH, the University College Hospital, and you bring someone to the hospital who is in a critical condition. They tell you there's no stretcher to bring him up. You have to pay a particular amount. You have to wait before the doctor arrives. Many of such stories you hear almost every day. What do you think can be done in this regard? Because at one hand is also providing all of the facilities that you have mentioned, making all of the policies that are lovely. But what about the manpower who also has the commitment and the right attitude to work?
Well, because I'm a medical practitioner, so it's easy for you or the listeners to think, oh, one could be biased. But the truth actually is that a lot of things go into this. I'll tell you something. I know that in the 60s and 70s, the University College Hospital in Ibadan that you mentioned was about maybe the third best hospital in the Commonwealth. And that's including Australia, Britain, and everywhere, Canada. About the third best. So practitioners struggled to come to the UCH to work. I don't know what that status is now, but it must be a lot far from that. And again, we say a lot of things. Most of these hospitals are overburdened. Majority of the cases that get to UCH in Ibadan or get to Luth here or Lasut in Ikeja need not get there in the first case. A lot of them ought to have been trapped at primary care level so that they are sorted out. By the time you have a strong primary health care system, you're also talking about good preventive medicine. But so you get less people, that serves as a filter, less people going to the secondary general hospitals, and then from there on to the tertiary hospital, the college hospital you are talking about. But what do you get? You find out, for example, that everybody that has a diarrhea, stooling, or headache goes to the teaching hospital. And so how many staff do you have there? I can assure you, where, for example, you probably have a ward with about 20 beds, and that you should ideally probably have a nurse to 4 beds or so maximum. Maybe you just get 1 or 2. You find out, for example, that what you think about 5 doctors should do or 6 doctors should do. Sometimes when we tell our colleagues abroad how many patients we see in a day, they marvel. They think you are miracle workers. So the implication of this, what I'm trying to talk about, is attitude sometimes is also a function of when you, it depends on the environment in which you're working in. Nobody goes out from their house in the morning to go and be hostile or anything. But we find out, for example, that sometimes the pressures can be much. So if you have a doctor seeing 40 patients or 50 patients, and you expect him to document, examine, see, and all that. So what you see, for example, is because you got to the hospital and they tell you that the doctor, I had somebody who I was on a program just last week, and somebody was relating to me how, yes, a patient was saying that the doctor did not attend to her on time. But she also was telling me that, yes, that doctor was the only doctor that was on that floor. But she saw that doctor also on another patient doing something. It was only after he finished there that he came to her. There's no, you don't have 4 hands. So the truth actually is that attitude, yes, there's no doubt about it. There will be a few bad eggs and all that sort of thing. I'm not saying that as doctors we are perfect in any manner, but I think that the average doctor in Nigeria he works everything off to make sure. It's pathetic, because when we talk about these mortalities, like I say often, you don't know how much the doctor or the nurse gets home to grieve on the patient he lost, or the patient she lost, or what ought to be and what not to have been. And then you find out, for example, that he expends his health, his strength, and everything. And the other time I told you that almost half of the doctors that are trained in this country, but the last time the Nigerian Medical and Dental Council was reeling off figures, you'll be shocked at how many doctors emigrate every day out of Nigeria, every year out of Nigeria, and how many, the few that come back home. India didn't do it that way. India that we all talk about, we go to India and all that sort of thing. India raised the standard at home. India paid well at home and all that. So it became unattractive to work in England, because you get the same thing working at home, because wherever you are, home is home. So those are some of the issues actually that I think really cause that. I don't think that, and then what is regarded as negligence, oftentimes it's probably just a misconception. That's the what you think it is, because negligence will not be, oh, they didn't attend, they didn't give optimal services at the time the person got there. If you said that they were looking for stretcher, for God's sake, if there's no stretcher, there's no way you will get a stretcher. The UCH you mentioned, I know as far back as 1963, 64. I know, for example, that you get to UCH, there are lifts, because it's a multi-story building, southwest, southeast, and all that. And then you get into those lifts, and every president in Nigeria, to the best of my knowledge, has been commissioning lift every year. They commission the lift, and the lifts break down. I'm not sure as we are talking that they are working.
Dr. Adedeji, I just want to have your summarized thoughts on all of this.
You know, let me just add to what Ireti has said. You know, and this is something that people must know. You don't bring a moribund patient and expect a miracle. Many times people bring patients that are close to them. They've kept them at home. They were feeding them with all kinds of concoctions. And when they can't mind, then they rush to it. No magic is going to turn that around. And you see, all this also speaks to our education. Health policy, health education, all these things, they go together. How much do our people know about simple management? I've seen a woman, when I was in teaching hospital, bringing a child. The child has simple febrile convulsion. Then she went to put the child near fire, and he got burnt. And many times you see women give their children cow's urine, and then you bring him to hospital, you say you expect the child to wake up. Cow's urine is poisonous to the brain. It destroys the child's brain. So you're not going to have a number. You see, I'm not saying we don't have attitude in the hospital. I would not say that. It also comes with the fact that the environment you work. If I'm seeing 40 patients and I don't have gloves, and I don't have this fig, and then all the things, electricity, and there's no running water. What do you want me to turn myself to running water? You know, sometimes we snap.
I can keep you guys here forever, but I think you might have to reschedule so we can also touch on some other issues ahead. The incoming administration, what your expectations are, you know, of the incoming administration. Thank you very much for finding time to come. I've been speaking with Dr. Oluwarotimi Ireti. Akinola is a consultant and obstetrician as well as a gynecologist, a member of the Society of
Gynecology and Obstetrics.
Thank you very much for coming today. Dr. Dokun Adedeji, a medical practitioner par excellence. Quite rich contribution that I got from you this morning. Thank you very much for coming. And that wraps it on the show today. We'll bring you an update sometimes very soon, probably at the top of the hour, of what's happening in Niger. We reported earlier that the Speaker of the Niger State House of Assembly, Adamu Usman, has been impeached by 18 of 27 members, with Isaka of Bida, one state constituency, now elected as new speaker. Our correspondent is there, and we'll find out also in the GP what's happening there. Cold Digest continues tomorrow at 9:30. I am Nifemi Oguntoye. Thanks for being there.
Core TV News, expanding your view.